Hello everybody. Can you hear me well? Great. So thank you so much for being here, and I'm very happy to tell you something about this beautiful instrument I've been the honor and the pleasure of using in the last couple of years. And do you hear me well? Yeah, great. So what about the technology that is behind this machine? We are more used for the interior segment of thinking about 1300 nanometer machines. And a good reason for using them is that we can go through the ESCRS. This is an experimental setup built in Bascom Palmer Eye Institute in Miami. And also the possibility of going deep is another good point for those machines. But 1300 nanometers is not the only possibility we have when we consider the good wavelength for analyzing a biological tissue. There are others. And if we move to around 830 nanometers, that's the wavelength that most retinal OCTs use, we have some differences, and I believe for our purposes some advantages. This is something that I cannot explain. I hope that it is isolated. I don't know. There were some characteristics about the instrument, but anyway, the two more important characteristics of this instrument, I believe, are its frequency, 840 nanometer light, and it allows to see very well opacities. This morning, I don't know whether some of you were attending the meeting organized by CSO in the hotel nearby, and somebody pointed out correctly that when we talk about opacities and optical density, this is something that we cannot translate to OCT images. In fact, OCT is using infrared light, so it's not visible light. So technically speaking, it's not light, it's not optical density. However, if we think at the wavelength span of visible light, it goes from 400 to close to 800 nanometers. And this is very close to that range, while 1300 is 500 micros away, nanometers away. So, in fact, whenever we see even the faintest opacity within the cornea, and we have a look with this kind of OCT, we can readily have a precise definition of that opacity. So it's not by definition something that we can use for defining the opacity, the optical density, but there is an extremely strong correlation between what we see and the opacities we see at the slit lamp, and sometimes also opacities that we cannot see. And you see the definition we can have within machine. This is also a benefit, this 3.5 micrometer precision, which is more than 3 times what we get with 1300 nanometer OCTs. And here, for example, you see the detail. The epithelium can be very well characterized. All the stromal layers, what happens at the iris, at the angle, here at the limbus, everything is extremely well detailed. If we compare with the 1300 very good instrument that allowed us to obtain at the limbus area after a biopsy for limbal transplantation, this is the area. This is a beautiful image with the 1300 nanometer OCT, but you see how nicer, how better the detail we can have with the 840 nanometer, like the one that CSO selected for building this beautiful machine that I've been working with. So what they did, together with implementing such a high resolution OCT system, is to add a Placido disc. The same, let's say, smart move they already did for combining Scheimpflug camera with Placido disc for the Sirius, that maybe many of you can have used and actually was extremely happy with. So we can obtain with this new instrument an extremely detailed morphology of the whole cornea, of the whole anterior segment. But it's not only visible that we see beautiful images, it's that we can measure on them, so our measurement will be extremely accurate. On top of that, we can also have, in addition, objective ocular surface analysis, so high-resolution tear film breakup time test analysis, which is becoming more and more useful. So we have that already in the same machine, we don't need something else. And also some dynamic information that can be easily combined with illumination from the Placido disc. So it's easy to obtain such movies. You see here we can see very well what's going on upon illumination to the iris, to an ICL in the anterior chamber. You see the space here, the vaulting is reduced during constriction of the pupil, and also the angle can be seen very well. In some cases, we can also have a look at strange surprises that we might face. Like in this case, this is the next day post-op in a phacoemulsification, and this is a fibrin layer, which is like a tent covering the iris, the pupil area. But then, maybe the most important point that we can exploit the accuracy of this instrument is, in general, corneal topography, because the combination with the Placido disc allows an extremely high precision for the anterior surface of the cornea. And that means more than 30,000 measurement points, and little less for the inner side of the cornea. The pachymetry map, it's not only for the whole cornea, but also for the epithelium, and I believe this is so far the only instrument on the market that allows such a precision and reliability in the analysis of the pachymetry of the epithelium layer of the cornea. And also adding, rather than a Scheimpflug, an OCT measurement, we have an extremely precise depth measurement in the cornea. So the pachymetry measurement we have, the posterior corneal profile is very accurately measured, and for example, it's very important, is not fooled like Scheimpflug images by faint opacities, as we can find, for example, very commonly after cross-linking procedures, or in other diseases, or in haze after refractive surgery. So posterior curvature and aberrations can be very reliable measurements, much more than with the other technologies. And also in the optics of measurements that can be used with the most modern formulas for IOL calculations, having an instrument that gives us a precise definition of the anatomy of the cornea means we can have a precise definition of the optical properties of the cornea, so the total corneal power is something that we can measure more accurately, and this can turn out in a better precision for IOL measurements. So seeing and measurement anatomical details in a detail that we didn't have before is really a plus, and that means clinically it's better decision making. We couldn't decide that well with the instruments that were less precise. With more precision, the more we learn to work with such an improved detail means better and better care for our patients. Better decision making, not only for medical treatments. For example, we can think about infections of the cornea, or uveitis, but also surgical planning is very important. And we hope we'll have in the future direct links of these measurements with excimer lasers and hopefully also with femtolasers. It's extremely important for the surgical follow-up and of course for laser retouching. Yes, with this precision we understand that details matter. And for example, in keratoconus you see how many details we can see about the stroma, about the epithelium, the inner aspect of the cornea. This is a much milder keratoconus case, and you see, besides the epithelium being modified, we have a little stromal opacity, and this is a more common case of keratoconus. And it's very interesting that not only we can see these beautiful, extremely detailed images, but we can have a look at maps. And it's not only the usual maps, it's also the epithelium map. And here we can verify what we usually assume, but we can both verify it and measure it. That is, what is the epithelium doing? And here you can see very well the coincidence between the anterior curvature, the posterior curvature, and what's going on in the epithelium. The epithelium is much thinner in the area of where the cornea is more ectatic. And when the shape of the keratoconus is changing, we see that also the pictures change, and you see this is quite central keratoconus case, and you see what happens to the thinning of the epithelium on this cornea. And this is the corresponding image of the same patient, the same eye, and you can appreciate, I hope, with the resolution, how the epithelium, even the Baumann layer can be pretty well appreciated, and how in this area the thickness of the epithelium is definitely smaller than in this area. I hope you can see. Yeah, I believe so. The image is pretty similar to what I see on this PC. Also, stroma is something which you might want to have a detailed look at, like this is a DALK procedure after 1 year, but we can still see some details about the graft-host junction and how regular it is. The anterior part of the cornea is especially important because with other instruments we really couldn't see with such a detail. In this case, the external profile of the cornea is pretty regular, no major problem, but if we take a look at a higher magnification, you can see how this paracentrally, in this area, the stroma has been eroded by some keratitis that the patient encountered many years before. So we must be extremely careful, of course, in treating for refractive surgery such a case. And knowing and measuring what's going on is really important, and we can also have maps that show us where the epithelium is thicker or thinner. In this case, we can have a look at something that happens every day almost, or at least every week in our offices. That is a patient, myopic, wearing contact lenses, and comes to us for because he has the idea of getting rid of this myopia and getting laser treatment. But we see this strange anterior irregularity in the anterior curvature, and it's very useful, besides having a look at the posterior curvature that is regular, being able of checking the thickness of the epithelium. And here we can readily verify that this modification in the lower part of the cornea is due to an increase of the thickness of the epithelium. And so this is important because we can reassure the patient that most likely will be able to perform surgery, laser surgery. And then also in the follow-up, after the warpage caused by the contact lens, we can precisely not just guess in 10 days, in a couple of weeks, the warpage will be over. We can check whether that warpage will be over. And only when it will be over, we'll be able to make perfect measurements. Sure. Here is this is the epithelium. This is the anterior curvature. So, yeah, I'm sorry because probably in this picture of the epithelium is. Yeah, in fact. Here it's thicker and here it's thinner. This is. You cannot see my pointer.
I'm sorry.
Excuse me. The lower part is more, it's not ectatic, but doubted. There, the lower part has a thicker epithelium. Yeah. So it's not ectasia, it's contact lens warpage.
Must be at 6 o'clock exactly. Differentiate.
Yeah, sure. Yeah, that's another hint for deciding. But if we can also measure, then it's something also for follow-up. How long will it take for this contact lens warpage to fade away, and then we can measure. Right. This is after a myopic treatment, and we can follow the epithelium. Here is the epithelial thickness, and you can see how in a myopic treatment the thickness is higher in the center because we create kind of valley, of course. But we can measure it, have a look. This is also a myopic treatment, you see, but this is just the other way around because this is orthokeratology. That's the effect of orthokeratology. So ortho-K on purpose does just the opposite to obtain the same picture of something we can obtain with laser. It's also very important to me that we can have a precise look of what's going on with the haze after laser treatment. It's a PRK. You can see something is not perfect in the area, and we have very precise look in the depiction. This is after LASIK, and also here we see the interface is great. The interface we cannot see. This is one of the margins of a flap, and there something is going on. Very, very small ingrowth. But didn't go farther than that. This is still LASIK, hyperopic of course, and we can see very well the shape. It's interesting how clearly we can see the thickness of the epithelium in that area that is filling the increased depth at the margin of the treatment. Yeah. Exactly. Here we cannot see anything. This is a very nice case of a smile procedure, but in the same patient, if we rotate the angle of the slit of the scan of the OCT, we can see the entrance of our pocket. Sometimes after a smile, this was short after the smile procedure, the surface is not that perfect. And in this particular patient, I was very worried, but after 6 months, everything was fine in 2020. Yes, but yeah. In fact, in the beginning, she was a lady, a colleague of yours, and she took 6 months before recovering completely, and then we had the 2020 uncorrected vision and everything was fine. A few more cases showing how these details are interesting to look at. This is mirroring the two eyes of the patient, a 6 millimeter mirroring on top, 5 millimeter diameter mirroring, and you see this is a more severe keratoconus than the one on top, and here you see all the modifications of the thickness of the epithelium and the distance of the ring, all the details are there. It's very nice, and we can also have a look at those details as a map, so all the points can be measured. We see what's going on. It's interesting in this respect to see the worst eye, and you see the anterior curvature before and after the treatment, the posterior curvature before and after the treatment. So of course the anterior curvature is heavily modified, and we are very happy about it, but the posterior was not. But as we know, the posterior is refractively much less important, so no problem. Another interesting point is looking at the epithelium here, and we see how in the still more ectatic area of the center of the cornea, the epithelium is thinner. And while on the other, the epithelial, this is the old thickness, the epithelium is much thicker, of course, in this area. And as these things happen inside the circular ring, they both cooperate in improving the curvature of the eye. So it's a very effective and very little invasive treatment. It's another case that shows some features of this instrument, how useful it was. This patient, I don't have the first image. He had a bullous keratopathy, more than one millimeter thick cornea, and he had already, he told me that he already had penetrating keratoplasty 20 years before and wanted to get better but didn't want to go through penetrating keratoplasty again. So I say that first thing we have to do to perform an endokeratoplasty. So we did, everything went well, and the thickness recovered, but then we see a few things. One is that below the epithelium the surface is not regular, and it's not regular in a way that is not just, it couldn't be only the effect of decompensation of the cornea. There is something, in fact I asked the patient, but didn't you have any laser after your penetrating keratoplasty, then he recalled that he had actually. And so we had to make a decision because vision was not good in that case. And so we made some, let's say, resurfacing with a custom laser procedure. And we obtained a very regular cornea. And so without the opacities, of course thinner, but the cornea was in a decent shape.
More thinner,
Yeah, thinner. Yeah, we ablated with Excimer laser, but still.
3 times
Yeah, no. Was both PTK, some PTK plus a custom ablation. Ah, I see what you mean. Yeah, the one for keratoconus. Yeah. And as the patient had cataract and residual regular astigmatism, we went for cataract extraction and add-on toric IOL implantation, so that in case we in the future have to do something to that cornea, we can always take away the add-on IOL and go on with other surgeries. Just one more minute, I show you how useful this instrument can be when we perform some other surgery on the cornea, like this is a case where with initial decompensation in Fuchs dystrophy, and we performed cataract, and with the patient we discussed a lot, but we tried to do primary decimatoresis without transplantation. In fact, we had a disaster in the beginning, of course, but then you see after time most of the cornea recovered, and both also the transparency. But it's interesting because with the instrument we can have very detailed information about it. You see, this is the sequence, the total corneal thickness and the posterior curvature, and you can see how in the area of the central cornea the recovery was not the same in all areas. The top area on the superior area recovered more quickly than the inferior one. And it's nice then to go back to the scans and have a look of what's going on. And here we can see beautifully how the decimate removal can be very well delimited in the image. We can see where it's left and where we took it away. This is after the surgery, so there is not edema anymore, and the endothelial microscopy shows us that in that area it's around 1,000 cells per square millimeter. Yeah, it's low, but it's better than nothing, as we did.
What about hexagonality?
I don't recall that. I was already happy that we had some cells, transparency, that the patient was already seeing, but we'll keep examining the patient in the future, and I hope that she will recover a little more. But anyway, we decided to do this procedure because the peripheral density was pretty good, was 1,500. Yes, a little bit, yes, because in the beginning the cornea, now the central cornea is thinner than in the beginning. So, yeah. And this is the very last thing. This point corresponds to the area where the recovery was slow, most likely because endothelial cells cannot migrate over this irregularity. So it's beautiful with this instrument. We can see things, measure them, understand a lot. And so I thank you so much for your attention. Thank you.
Grazie, dai. Guarda, il prossimo speech che sta aspettando, mi ha fatto